Welcome, everyone. Thank you so much for being here today at the Fall 2025 Center to Advance Interprofessional Education and Practice Interprofessional Student Showcase, where we're going to be celebrating the work of 18 different teams today with 47 student participants in 13 programs and 18 active faculty and other mentors making it happen, although, of course, we're supported by many other folks throughout the year that make it all possible. So my name is Chris Hall. I am the director of the center, and I'm joined here by Michelle Cody, who is the program coordinator and the developer of that fantastic video we just watched. I'd like to give a shout out to Lee Cody and Dave DeDiego, who are working in backstage to make sure that this all runs smoothly, and of course to our track proctors and facilitators who you will see in the breakout rooms who will help everything run smoothly as well. I'm going to turn it back over so that you can hear from the Interprofessional Student Group has prepared a little video for us, and they have a lot going on in the spring. It's been a wonderful time having the College of Medicine here and being able to bring students together in more social ways than we in CAIEP have generally been able to do. And so they're going to talk a little bit about that, and I'll play their video now.
Welcome to the Interprofessional Student Showcase. We are IPSG, the Interprofessional Student Group, and I am Morgan, a second-year medical student. We'd like to take a moment to acknowledge what interprofessionalism means to each of us, as well as highlight some upcoming events and ways for others to get involved.
Hi everyone, I'm Luke. I'm a first-year PA student. With my clinical experience in the emergency department, I found that interprofessional care is vital in creating a diverse team of physicians, physician associates, behavioral health, and a multitude of other professions. With this team-based approach, it allows us to enhance communication and promote shared decision-making, leading to a more comprehensive patient-centered care.
Hi, I'm Jordan. As a student physical therapist, interprofessional care means creating a space for the medical care team to work together to promote patient safety and improve patient outcomes. Patients are multidimensional, so the more that we can encourage interprofessional care, the better we can help them recover and heal.
Hi, I'm Caroline, a first-year pharmacy student, and in pharmacy, interprofessional work means making medication therapy safer, more effective, and truly patient-centered. When prescribers, nurses, and pharmacists collaborate, we prevent errors and create better outcomes and ensure the patient's understanding of treatment plans.
Hi, my name is Alexa, and as a nursing student, interprofessional care means communication. Nurses are with patients at their most vulnerable moments, and partnering with other professionals ensures that every voice is heard, especially the patients.
Hi, I'm Julia, and as a second year medical student, I've learned that I'm just one part of a much larger healthcare team. Interprofessional collaboration means recognizing that we do our best work when we combine our different strengths, which leads to safer, smarter, and more meaningful care. Interprofessional teamwork means recognizing that no single profession can meet all a patient's needs.
Hi, I'm Rebecca, a first year medical student. We wanted to let everyone know that we're closing out the year with a Huga night on December 8th, a time for relaxation and coming together. Come spring, we're excited to offer volunteering with Preble Street Food Security Hub on Sundays and Partners for World Health, Sim Escape Room, Interprofessional Donor Lab and Surgery Club opportunities, as well as an interprofessional pickleball tournament.
Congratulations to the teams on completing your interprofessional project. If you're interested, please reach out to ipsg@une.edu.
Thanks to IPSG, Morgan and all for putting that video together for us. It's always great to hear directly from you, and I look forward to supporting your activities in the spring. And I think Michelle is putting the list of activities in the chat so that you'll have that to refer to. This is a list of faculty mentors as represented in the projects today. Without their commitment and the generosity of their time, we wouldn't be able to offer as much as we do, as well as we do. They make all of it really possible. So thank you from all of us to you, faculty mentors, for participating throughout the year, as well as in this semester. So we have a nice spread of different professions, folks from different universities, and everyone very committed to making sure that the remarks that we just heard in the video come to life for as many students as possible. So thank you for that. And now I'm here to just preview the navigation that you're about to undertake as participants in the showcase today. So the brochure is in the chat, and I encourage you to download it. The first page shows you the navigation, and the second page shows you the details, a little bit more of the details of the presentations that you'll be seeing, and you are free to move about. So there will be a minute of time between every presentation and Q&A, so that you'll have time to move about. So if there's one that you want to see in the first breakout room and one you want to see in the fourth, you are totally free to move around. So there are 4 breakout rooms. The first one is leadership. The second one is collaboration. The third is whole person care, and the fourth is social drivers of health. And they'll be labeled as such when the breakout rooms are open, so you'll be able to navigate to them. And we have such a great range of presentations today for you. Everything from the traditional interprofessional team immersion sessions that we're accustomed to offering here. Obviously, FIT has a good representation here as well, with some new things. We have a presentation from IGEP, which we're excited to offer you today, the Interdisciplinary Geriatric Education Program, which is in whole person care in the 1229 slot. And we also have the interprofessional Michael simulation is represented twice. So 2 different teams of students who participated in the interprofessional simulation in the Sim Center in person, not virtual like IPTI and FIT are, and giving them a chance to collaborate with a standardized patient to have a clinical experience that way. And so we're looking forward to sharing these all with you. And Lee will be here in the main room. So if you get turned around or lost as you're navigating through, you can always come back to the main room and he can help navigate you. So Lee, I think if you want to go ahead and open the breakout rooms, take your brochure with you folks and go ahead and navigate to the room of your choice.
Understanding Roles and Perspectives for Compassionate Care, an Interprofessional Approach, presented by Courtney, Tatiana, and Benny, all of which are students at the University of New England. First, a special thank you to our teammates. Our team was made up of many different disciplines from UNE and Rosalind Franklin, including physical therapy, dental hygiene, public health, dental, allopathic, and osteopathic medicine. Also, thank you to our peer facilitators, Sarah and Jennifer.
Have you ever collaborated with an interprofessional team and found yourself uncertain about teammates' specific roles and expertise?
Our approach really focused on the importance of team collaboration and understanding to truly provide patient-centered care. We prioritized open and transparent communication, giving clear representations of each of our scopes of practice and sharing our unique perspectives, while giving active listening skills and mutual respect to each other in order to foster shared collaboration.
Using our initial approach, we were able to focus on obtaining subjective medical history and information from Alex as a team, utilizing our discipline's roles and scope of practice. We first understood each discipline's scope of practice and organized and assigned roles in patient interaction. We then developed and asked patient-centered questions to address diverse medical needs, actively listened and documented Alex's subjective report, and provided empathy, reassurance, and support to Alex by recommending further follow-up care.
The initial view of Alex's case was more of a clinical perspective, so we looked at his community, presenting signs and symptoms, his use of substance abuse, and mental health.
Going into our second care session with Alex, we adjusted our plan of care to really focus on how to best support Alex and regain his safety and normalness in his life. We first assessed his readiness for change and gained his consent in order to refer him to social work, help get a Maine care and ID set up, assist him in a stable housing and work program, support and guide him with drinking and smoking cessation, and facilitate referrals to support groups and community resources.
By using an adjusted review of Alex's case, we were able to identify his family history of addiction, his source of receiving substances, understanding his reasoning for not receiving prior care, and identified his housing placements based on his and his friend Bobby's perspective.
In conclusion, the EV's team approach centered on collaboration and mutual understanding to provide patient-centered care. We achieved unified, coordinated, and compassionate approaches to patient care.
Thank you so much for listening.
Great. Thank you so much. Tatiana and Benny, we're actually opening up the floor for questions and answers. So if anybody had any questions for Tatiana or Benny, they are here in the breakout room. But yeah, so I did have just a quick question. I'm just curious, how did the experience go for you guys? Or how were you able to like coordinate who's going to do what during that experience?
The experience was pretty amazing because we were able to collaborate with different like scopes of practice and then like understanding like which role each person had kind of through like the clinical perspective of session one helped. But then once we got to understand our patient, we like formed like together as a team. So when we came to session two, we were able to understand like the needs of Alex.
Yeah, it seems like guys had really great communication. Was there anything that surprised you about that you learned about the other profession?
I think we had a greater appreciation for all of the professions, including professions that weren't included in our group, mainly social work being the main one. And we were really appreciative of everyone by the end. I think we went into the collaboration process, learning about each other's profession, and then as we went into our second session, I think we opened up more into an emotional perspective, which I thought was really neat. And I wouldn't have thought to gain that from a collaboration opportunity with different professions. So I really liked that. We all worked really well together.
Yeah, that's great to hear. Yeah, the emotional piece. Did anybody actually tear up during the experience?
No, I didn't. Like I felt uncomfortable during certain parts because I couldn't really like relate to the patient with certain things. But once I like was slow to speak and just wanted to listen to their story, then I was able to better understand what they needed from us.
And to add on to Benny's point, I think communicating and like allowing us to talk with the actor afterwards kind of put it in perspective, how they were able to put themselves into that role, especially because their lives are so different from what the patient's history looks like. So I appreciated them and they took their time to explain how they got themselves into that process and what that looked like for them.
Yeah, that's interesting, taking on the actor role in that situation, huh? Yeah.
I don't have a question, but I was one of their facilitators for this group, and it was really cool. This was the first time I'd been a facilitator, and it was really cool to see all of you guys work together, and you really didn't need much guidance, which isn't a bad thing or a good thing. It just happened to be that way, but you guys did a really good job of identifying Alex and helping him out the best you could.
That's great. That's great. Yeah, and just as a heads up, the next presentation will start promptly at 12:20. So, it being 12:19 right now, you can either stay in the leadership track and listen to the next presentation, or you can navigate to the other breakout rooms and see if there are other presentations that you're interested in. But yeah, thank you, Tatiana and Benny. Really appreciate it. It was a great presentation. The next presentation is called Interprofessional Collaboration of Patient with Chronic Infection.
Hi, we are Group 6 of PHIT program. I'm Marissa Ciccarini, first year comm student.
I'm Jordan Burnett, a second year dental student here at UNE.
Also in our group is Morgan Cheney, a second year comm student, and Purnima Mathur, an MSN and DMP student at Rosalind Franklin University in Chicago. And our project is about a generated case, analyzing different social determinants of health and creating interventions for her. And our patient is a 67-year-old female who I based off of patients that I saw in my practice at an obstetrics and gynecology office in Connecticut. And her main risk factor was that she has recently transitioned to Medicare health insurance, which is no longer covering her preferred treatment for her chronic urinary tract infections.
Yeah, so we reviewed some of her risk factors and protective factors and categorized them as individual, family, and social, community, and environment. And to kind of start off, so she's on Medicare, which doesn't cover her medications. She's a widow that lives alone and doesn't have any form of transportation. But so her main social factors is the community that she surrounds herself with and a daughter who lives in North Carolina who she keeps up with regularly. In addition, the lack of having transportation has caused some issues in terms of getting to different appointments for her medical needs. So, some protective factors in this case would be that she goes on daily walks for exercises, she has weekly phone calls with her daughter, and she's a member of a senior center in her local area. And she also is able to get healthy groceries delivered to her home. And we came up with some interventions for this case in order to better help her needs. And this stemmed from both all family and social, which she uses journaling and tracking apps, and she loves to volunteer with her community. And she also likes to schedule her appointments during off-peak hours, which helps with the transportation factor, so she isn't stuck in traffic and always waiting for a car. And she also utilizes a ride-sharing apps. And then in terms of her Medicare assistant programs, there's a chronic care management program, which we recommend that she applies to through the Medicare Part B plan, which will help with her situation since she has two chronic conditions. And they will set her up with a care coordinator, which will overall help her experience.
Great, thank you so much. And now we're opening the floor for questions and answers. So yeah, feel free to speak up. And one thing that I kind of had in my mind, so either Jordan or Morgan, if you could answer this, I see that, the interventions kind of relies heavily on apps. So it seems like this particular patient didn't have issues navigating the apps and also, like, do you find other patients have this issue, and how would you navigate around that?
Sure. I think in exactly this case, she does not have any issues navigating apps. She is a widow and she speaks to her daughter regularly, so she's kind of had to be able to keep up to date with technology and adapt in that way. But to your point, exactly, that's not the case with everybody. So I think there would be some other interventions that we could offer for those that maybe don't have a smartphone or aren't as privy or savvy with apps. I used to work in this same area as well, actually, in Norwalk, and oftentimes we would call taxis or as medical assistants or secretaries in the office, we would make the calls for patients for those transports. And they're not ideal. Oftentimes patients would be waiting in the office for hours for those transports to arrive for them. So being a little tech savvy can definitely go a long way in this area.
Yeah, certainly. No, thank you for that.
I have a quick question just about geographic differences because it sounds like someone in your group is in Chicago. So when you guys were sort of figuring out what steps to take for this patient, was there any differences that you guys found that were, maybe resources in Maine versus in other states?
I can speak a little bit to that. We were the only group out of the PHIT teams to not do a case in Maine. So we got to hear a lot of like Maine resources. But we actually didn't look into Chicago or Maine ourselves, and we just focused on finding interventions in Connecticut. But a lot of the other all the other teams did Maine too. So I think Maine has like an abundance of resources compared to Connecticut. Those are like what we found, I think. And I'd be interested to see Chicago just because it's such an urban center and it probably would have more vast resources as well.
Yeah, did you come across like any particular like website or place to find these resources, or is it more of like connecting with like social workers?
I think it was a mix of personal experience and having worked in these environments and utilizing these resources on our own, and then definitely collaborating with each other and just learning about these different resources that we've each been exposed to.
Yeah, Morgan and I both worked in like Fairfield County in Connecticut. So we like both took our experiences from that into this.
Yeah, great. Thank you. So, you know, we still have a minute before we can start making our transition into maybe another breakout room, or if you want to stay on this leadership track for the next presentation, please stay. But yeah, so the next one will start promptly at 12:29. Were there any other comments or questions for the presenters? It doesn't seem like it, but yeah, thank you, Morgan, and really appreciate the talk and yeah, best of luck with the rest of your studies. So it looks like the next presentation is called An Interprofessional Guide to Approaching Patient Care from UNE and RFU students.
All right, hello. We'll just do a quick introduction of everybody. My name is Leanna. I'm from the physical therapy department or program of physical therapy.
Hello, my name is Rosalind Helen Haley, and I'm a graduate student in the public health department at UNE.
Hi, my name is Trisha Shukla. I am a first-year med student at Rosalind Franklin.
Hi, I'm Elise Madelone. I'm a second-year medical student at UNE.
And my name is Farah. I'm a third-year dental student at UNE.
So today we're just going to go through how we went about the case with Alex and how we all collaborated and worked together to make his care holistic and effective. So first we'll just quickly start with Elise and Trisha with their like medical perspective, how they contributed.
Yeah, so from a medical perspective, I think it's really important to go about patients like Alex and acknowledging that there are systems that create barriers to care. It's not the patient's fault. Using a trauma-informed, non-judgmental care, integrating those social determinants of health within the care, screening for lack of access to food or housing, and then using our interprofessional team, which we were able to do throughout this project, to create a plan and shared decision making with Alex.
Yeah, additionally, I also think that some things could be added, including just how the interprofessionalism works. So we really collaborated together in order to create that customized treatment plan, in order to ensure that it is continuously being evolved and in the best interest of the patient.
From a physical therapy standpoint, similarly using the trauma-informed care and collaborating, coordinating with other healthcare professionals to add to the team.
From a dental perspective, definitely educating about prescriptions that can help alleviate mouth pain and also discussing at-home dental treatment, allowing for easy access, as well as like long-term care at a dental home standpoint after oral pain is figured out.
From a public health perspective, I found that it was very important to look at the patient holistically, not just the symptoms, things that were going on in the patient's life, such as transportation, effects of childhood trauma, consequences of food insecurity, and the role of substance abuse, and how issues are created in the life through how those facilitate issues in life.
So yeah, we're opening up the floor now for Q&A. So or comments, if anybody has anything to say, please feel free to speak up and maybe turn on the video, see your lovely faces. Yeah, I see a couple of our presenters here, Trisha and Elise. Yeah, listening to your presentation, I actually was curious about, in your program, have you had any content about trauma-informed practices?
We do these on-doctoring sessions at UNE. I'm not sure if you've heard of them, part of the COM program, and we did have a trauma-informed one this year in second year, but otherwise it was just a few hours. Otherwise, within our main curriculum, we don't really have much information, unfortunately. There are certain OMM techniques that might feel more invasive, so we'll give like a disclaimer and always ask for consent and say if you're not comfortable, we'll stop. And that's always the spiel, like whether it's clinical or OMM that we're doing. But it was definitely eye-opening and a good way to expand my skill set that I feel like I didn't get completely at COM doing this case. So that was awesome.
Yeah, that's great to hear. That you guys had that exposure. Uh, if this being an IPD experience, so you were working with a actor patient?
Yes.
Yes. Did they play out the role of just like kind of having that sense of like traumatized past, and how did it affect like your interaction with this patient?
Yeah, I feel like Trisha, you probably agreed that he was pretty good at sticking to his character. And then at the final session, he kind of like came back to himself, and then we like discussed how the case went. But he was great at like sticking to the character with having lack of like housing and food and transport. So that was really like a really good experience to be able to get that exposure for that standpoint, because a lot of our standardized patients don't have that background.
Yeah, thank you for sharing that. Did you find it challenging with this kind of background and how to, just with the just interaction with this patient?
I think that I kind of found it challenging, especially in the first session, and having to navigate first telehealth and then also the trauma-informed care. So I'm at Rosalind Franklin in Chicago. We don't do a lot of telehealth like as much in class or practice. So I thought that was interesting, especially to see that in and work with an interprofessional team. And then I think then navigating like trauma-informed care, I just started in August. So a lot of this in terms of we've had like 1 or 2 sessions about trauma-informed care, but not a lot. So I think it was really insightful to just learn how to navigate or some of the techniques that are used.
Yeah, thank you for sharing that. Yeah, it's definitely different demographics, Maine compared to Illinois or Chicago specifically, right? Yeah, it's thank you for sharing. Like that is interesting that they don't necessarily have telehealth in Chicago, but I guess it's, transportation is not as much of a barrier over there.
I'm sure they have telehealth. It's just we like haven't been exposed to it yet, or like the use of it and just having to interact with a patient that won't necessarily give you all the information. Like all of our or the ones that I've done, the current patient case scenarios, they've just like not offered it up, but I haven't had to push as much, I guess, as we did with this patient, or kind of having to ask a lot more questions in order to get like answers to certain questions.
Gotcha. Yeah, and our next and final presentation for the leadership track is collaboration, a team approach to youth well-being.
What would happen if every patient you met felt genuinely heard? Consider what would change in their health and what would change about your own. Hi, everyone. My name is Libby Shea, and I'm a first-year UNE student presenting the work that I completed through an interprofessional conference scholarship with UNE's CAIEP program. This project, titled The Power of Listening, Collaboration for Wellbeing, is inspired by what I learned at the 2025 Maine Youth Thriving Summit. At the summit, we began with a simple yet powerful question. What does it actually mean to listen? According to the Merriam-Webster dictionary, listening is to hear something with thoughtful attention and to give consideration. But the youth that we spoke with pushed that definition much further. They helped us understand that listening is not just hearing someone, it's creating a sense of mattering. Their desire to feel that they matter is not just an important request, it's urgent. According to the 2023 Maine Integrated Youth Health Survey, 50% of high school students in Maine reported that they do not feel that they matter in their community. You will see within the next few slides here that there are several pathways we can take to try and change this. When young people feel unseen, unheard, or disconnected, their resilience will weaken. And as our researcher Jennifer Wallace shared, the resilience of the youth relies on the resilience of the adults in their lives, and the resilience of the adults depends fundamentally on the relationships of the adult. The core message here is asking what this means for us as future healthcare professionals. First and foremost, it means that listening is not optional. It's a community responsibility that all of us need to uphold. Across the summit, there were 3 consistent themes that emerged. The first one being active listening and curiosity. Active listening is more than just nodding your head when someone's having a conversation with you. It's more along the lines of asking open-ended questions, reflecting back on what you heard, and checking that you understood them correctly. Another important tactic is creating meaningful connections. Youth want genuine relationships. They can tell when we're distracted, rushed, or pretending to listen. Taking even a few moments of quality time sends the message that we think that they matter. The last one is affirmations and acknowledgement, which is one of the biggest takeaways from the summit. When you understand your own value, you naturally uplift the people around you, from your patients to your coworkers to even some of your closest family members. With this, it's imperative that we work with others around us as well. Whether you work in community health or in education, listening is at the heart of effective collaboration, which is where every profession comes in important play. In healthcare teams, strong listening supports communication, teamwork, and shared decision-making. The stronger our relationships, the stronger our outcomes, and the better our youth will begin to feel. You have all accomplished great things to get where you are today. Use those experiences to uplift the patients you serve and the colleagues standing right beside you. You're all here for the same mission. Ask more questions, be curious, and above all, listen in a way that helps people feel that they matter. Thank you.
Great. Thank you so much. That was a wonderful presentation. So, we're just opening up the floor for Q&A and any comments that you might have about the presentation you just listened into. Yeah, and feel free to open up those videos, see your faces.
Well, I've been pretty quiet throughout this because Gail, you're in charge of the talking, but I wanted to give a special shout out to Libby because I was at the summit with her, and I'm so appreciative, Libby, that you captured this so well because it's just so nice to reflect and look back on that day. And it was such a full day and it was such a great experience. And you really captured it so well. So great job.
Thank you. I think one of the biggest takeaways too, I think there was a question coming, but one of the biggest takeaways for me was just being able to take advantage of that opportunity that the IP program gave to me. I think is something that not a lot of students really do enough. So as those opportunities come out, I think it's definitely important to at least take a look at them and see what we can learn.
No question from me, just echoing because I was just listening to the enthusiasm coming from that presentation. So Libby, very well done. I love that topic. I think it's so important, not only for the future of the students and everyone that we touch, our patients, but it's just, I think it is the future. So I really, really like that topic and I really appreciate that. So very well done.
Yeah, I definitely have to agree. I think being a true listener, right? Not just acting like you're listening in or just absentmindedly documenting while the patient is talking, but to actually make those genuine connections. I think that is very key. So this Maine Youth Summit, it was mostly focusing on care of the younger population, right?
Yeah, it was kind of, go ahead.
I was just kind of curious. You had a quote about also connecting with it depends on the relationship with the parents as well. And I wonder if there was something that they had talked about during the summit in connecting with the parents, not just the youth.
I think it was mostly the topic of conversation there was that as youth, they want us to acknowledge our differences as adults. And so noticing the difference between the two there and establishing that, I guess, power hierarchy, I guess would kind of be an okay way to describe it. But they also emphasize that our relationships as the adult in the patient or whatever that professional relationship going on is that they want us to have stable relationships too, because we can't bring our best selves to the table unless we are taking care of ourselves and filling our own cups and making sure that we're feeling like we matter, because we can't help the youth feel like they matter if we aren't doing that for ourselves. I think that was the most important takeaway there. And they brought a special guest author in that did a really good job talking about that.
Thank you. That really resonates with me. Absolutely. I mean, it's just like you say, we need to be able to fill our cups first before we can help others. So yeah, thank you very much for this presentation. It was really great.
Thank you so much, you guys, for giving me the opportunity to present. I learned a lot and I am definitely going to continue with this pathway. I think it was great.
Thank you so much, Libby.
So first up today, I'd like to introduce the Michael experience. And this team is going to walk us through their kind of interprofessional approach to the Michael simulation. And they really highlight communication, role clarity, and then a shared decision making in the very complex patient scenario.
Charlie. I'm a doctor of physical therapy student at the University of New England, and this is my partner.
Hi, my name is Purnima. I'm an MSN student at Rosalind Franklin University.
And this is the Michael experience. So the setup for this experience was simple. We had a big meeting in our innovation lab at UNE, and then we had a smaller meeting with our individual teams. And throughout those meetings, we had 2 encounters with our standardized patient Michael, with 1 break in between those encounters. And the encounters went well. We had 4 different disciplines on our team: PT, OT, dental, and nursing. And each person brought their own different strategies and perspectives, and we were able to combine to 1 plan at the end. And our main focus with Michael was pain management. And what we learned from this event was teamwork works better if prepared for. All these reviews and meetings helped us a lot. And we also had to think outside the box because Michael came up with concerns that we weren't ready for, but we had to think quickly to figure out how we can better assist him. And the main focus of this event was interprofessional collaboration, obviously, because we had so many different disciplines.
Major Michael concerns were chronic pain because of his frequent falls, and him self-administering marijuana for managing his pain, and distrust in healthcare because he's not able to follow up, lack of transportation, relying on his granddaughter and his friend for him taking him from home, hospital visits and everything, which creates a gap and distrust in healthcare as he's not seeing better results and outcomes. So PT suggested electrical muscle stimulation. Nursing mentioned about possibility of home health visits and involving social worker actively on this case to give resources like transportation, reviewing his VA benefits. For dental, hopefully there could be a possibility of them involving in home health visits, or how could the transportation be arranged. And smoking cessation could be a very critical part of this, as he may have experienced hypertension and earlier because of his falls. Experience was well organized. It felt real and dynamic. It was the first time many of us worked with PTOTs and dentists disciplines in such a direct way. We now better understand how and when to refer to each discipline. It gave us a model for real world interprofessional teamwork, not just in theory, but in action, emphasizing on patient-centered communication, adaptability, and clinical reasoning as a united team. Thank you.
Wonderful. Thanks so much to the Michael Experience Team 1. I think you're both here. Do you want to give a wave to everyone?
How's it going?
So I'd love to open it up for questions. We have a couple minutes. If anyone here wants to jump in, I can take the first one. It's pretty clear that you were thinking not just about the clinical picture, but also how Michael overall was doing. Wondering if maybe you could share your most challenging moment of the simulation and how you all work together to solve or approach that.
Yeah, I think the most challenging part was the unpredictability. I mean, he did a great job, the standardized patient, Michael, throwing all these questions at us. He had the smoking thing. He had the distrust with the health care providers. He was living in a rural area. He needed family and friends to, drive him to appointments. So it was a lot of moving parts. But having different, brains in the room, PT, OT, nursing, dental, if I missed something, somebody else would mention it. So it was really good to have that help. So I think it went.
And just to piggyback on that, sometimes you come across patients and they only share the information in parts, and unless you cross-check with them, do you have this too? And they're like, oh yeah, I have this too. And I was like, okay, well, because he didn't tell us he smokes until in the second meet, second half of it, and we were like, okay, that's the deal. For the hypertension, you need to stop doing that. You cannot do that.
Great. Jennifer, I think you have a question.
Hi, nice job. I'm wondering sort of what your takeaways are as you move forward in your programs, what was like an aha from the case that will maybe make you think differently about your course content or the patients that you'll encounter along the way?
Yeah,
Go ahead.
okay. I was gonna say that the biggest thing was like it's a different like mindset to think in a group. Because, as a PT, when I saw OT, dental, and nursing bring up so many good points, I'm like, wait a second, this is, different than when I'm by myself as like just a single provider caring for the patient. So that was a big thing. And then even right now, I'm on clinicals, like seeing in the real world, that's how the dynamic is. So it's good that I did this experience on my first year, I think, because it's like a mind opener, kind of like that's how the real world is. It's not just one provider. So I think that's the biggest thing I would take from the events.
Thanks.
For me, like just a quick thing was that like actually putting yourself in like patient shoes, like actually analyzing the environment they're living in, because it's so easy to say like, oh yeah, have like transportation, have a follow-up, but not knowing like, does he have a car? Like he has anyone to like take him from point A to point B. So those kind of like small things to pick on, like which is kind of causing the gap in like, the healthcare.
Yeah, thanks. Thanks very much for those responses.
Well, thanks everyone. Believe it or not, I think it's time to step on up to the next room. Thank you so much to our presenters. Hi everyone. I'm Abby Leiden. I'm faculty at the College of Pharmacy and in the Baldwin Institute at Rosalind Franklin University. Happy to be here. We got 10 inches of snow, so totally dumped on. I'm excited to introduce our next presentation. It's from the Seeds for Growth team, who designed a campus-wide mental health awareness and outreach event.
Hello, everyone. My name is Amelia Tata. I'm a second-year MSOT student presenting today with Rachel Parker, a third-year DPT student. Today, we are sharing our project, Seeds for Growth, students educating, empathizing, destigmatizing, and supporting for growth in mental health awareness. This was a service project event hosted last year by a group of my classmates and me to raise awareness of mental health difficulties among healthcare professionals. When we started to plan the event, we knew that it would reach more people and be more successful if we made it interprofessional. We invited 10 programs and 6 of them set up tables and activities at the event. We collaborated closely with PT to make the event accessible and welcoming to all. Let's break down the collaboration a little bit. While preparing the event, my classmates and I completed a needs assessment and identified the benefit of creating an interprofessional event.
And we wanted to create an open environment for inclusivity and accessibility. The tables were set up so that the foot traffic was inside and patrons would be able to utilize activities at each table with plenty of space. We collaborated to decide on activities to promote leisure and physical activities that are prioritizing self-care to reduce burnout. Research has found that consistency and a routine for self-care reduces feelings of stress and anxiety. So we wanted to implement a home exercise program that can still be high intense and be easily performed across various populations and requires no equipment. For interprofessional work, while we are both in therapy roles, I feel like we both have come to an understanding of how much we are able to overlap, as well as the differences that encapsulate our perspectives through the OT-PT lens. As Amelia was able to deduce specific leisure occupations that could focus on the self-care needs, I was able to also bring in evidence-based research to promote neuroplasticity and activity recommendations that both coincide to reduce burnout, stress, anxiety for healthcare workers. For the PT perspective, stress and anxiety from research causes uncomfortable emotions and physical sensations that are effective responses similar to psychological changes. These occurred during exercise. Integrating the appropriate intensity with low joint reaction force can reduce the sensitivity of these negative feelings and the effects of burnout through a consistent routine.
From an OT perspective, we put a handout on the OT table where we wanted to prioritize presenting activities and tasks that people could take with them and put into practice in their own lives. We did this through focusing on a wide variety of occupations that bring meaning and joy to a client's daily life, while making them physically and emotionally accessible to everyone. In conclusion, by creating an interdisciplinary event, we were able to focus on our strengths within our respective scopes of practice and develop a primary focus as an interprofessional team. By engaging with our presentation today, you are helping us move the needle towards a more accepting and understanding field. Thank you again for the opportunity.
Thanks so much to the Seeds for Growth team. I believe we have at least one of our members here. Do you want to give a wave, Amelia?
Hello. Yeah, Rachel has a huge test today, so I told her I'd take over.
Had some makeup exams today.
Mhm.
Well, I really thought this was such a great example of how interprofessional collaboration doesn't only happen in hospitals or clinics, but also in how we design community outreach. I'd like to invite the group here to raise your hand and ask some questions at this time. Go ahead, Cameron, please.
Hey, thanks so much for sharing. I'm wondering if you were able to sort of share this with any of your intended audience and whether or not sort of it worked. So it was a wonderful sort of framing, but I'm wondering the extent to which it is actually effective.
Yeah, great question. Attendance is always difficult. I think that we spent probably 3 months reaching out to maybe closer to 6 months reaching out to all different programs, not only to be involved, but like if you don't want to do the work of setting up a table, come, like show up. I would say that for the most part, always in occupational therapy, like our biggest thing is we want people to understand what we do and why we do it. So there is definitely a huge misunderstanding of OT in general in the medical field and in the world that so much of our goal was to build something that future cohorts could do for their service projects. So like we had to start from scratch. Last year, our lovely professor, Carol Lambden Padavina did this project with a mental health clubhouse who ended up not doing it with us. So we were starting from scratch. Attendance wasn't where we wanted it. We had probably 10 to 15 people stop in, including a dental student who we hope we convinced to join the new cohort. The biggest thing I think for us was in that effort of trying to get other clubs, other disciplines to join us, and then also some undergraduate clubs. Like we had applied exercise science as a major and a club, for example. Not only getting out the word of OT and interdisciplinary collaboration, but just you're allowed to have mental health difficulties as a healthcare professional. You don't have to be this crazy strong person. So with that being the goal, I think overall we definitely did what we wanted to do, and in setting something up that next year's crew can build on and make their own, but the foundation being laid, we definitely did that as well.
Great, thanks.
Thank you.
Any other questions amongst the group? Well, here's one kind of thought, and it's a little going on what you just said is maybe how did you feel like having multiple professions at the table impact the design of the event compared to maybe what it would have looked like if it was just one profession that planned it?
Yeah, so I think that was something we heavily took into consideration. I believe there were 6 of my classmates and I, and originally it was just OT puts on this mental health event to destigmatize, and we took it in the direction this year of for other healthcare professionals, not necessarily destigmatizing for healthcare of our clients and other things like that. I would say that we really started with just OT to get us to the point of deciding to be interprofessional. We did stay pretty OT centric just to get a baseline so we would know what we needed help with in the first place. Because the second there's like all 6 different disciplines, 6 people on a team. It's way too many cooks in the kitchen to make it productive. So I would say that by at least establishing a groundwork and a common goal in general, it made it easier to include everyone down the line and give everyone more say on their section.
Excellent. Thanks so much. Well,
thank you
for sharing this with us today. And believe it or not, it's time for everyone to hop on to the next group. So congratulations to your team. I'm excited to be here. I'm Abby Leiden, faculty from the College of Pharmacy and Interprofessional Institute at Rosalind Franklin University, and excited to introduce this next group. So bridging some barriers in the public health problem solving paradigm in interprofessional team training. And we'll start off by looking at the video.
Hi, I'm Michelle Zareen, OMS 2 at UNE Com.
I'm Alexa Lantier. I'm in the nursing program at UNE.
I'm Andrew. I'm in the PharmD program here at UNE.
And I'm Haley LeClaire, a first year in the OMS1 Unicom program.
Patient is Peter Agaba, a 25-year-old man who arrived in the ED with severe back, chest, and limb pain that escalated rapidly within an hour. He appeared fatigued, dehydrated, and showed signs of sickle cell crisis, and lab findings supported this. Mr. Agaba recently immigrated from Portland, Maine to Uganda, where newborn sickle cell screening is not routine. He is currently unhoused, searching for housing and employment. His lack of transportation, financial barriers, and lack of knowledge about local resources prevented him from seeking medical care until now. Despite these challenges, he's motivated to receive medical treatment, obtain stable housing, find employment, and build a supportive community network.
For this case, we identified factors like social determinants of health that are impacting Mr. Agaba's care. We identified individual factors, family and friend factors, factors within the community and the environment. Some of the big ones were his sickle cell, having type 1 diabetes, opioid dependency, not having any friends or family in the area, being unhoused, and not having transportation or any knowledge of resources within the community. But some of the supportive factors are that he has a willingness to seek care and get better.
Some of the short-term interventions we have for him include his inpatient plan, getting his sickle cell crisis under control via an aggressive pain management schedule, blood transfusion, oxygen therapy, and social work consultation. For outpatient, we're going to schedule a hematology referral, begin hydroxyurea, pain management, and routine laboratory monitoring and renal function monitoring. For his type 1 diabetes, we're going to begin short and long-acting insulin. And for lifestyle and supportive measures, we're going to seek nutrition counseling and sleep and general wellness support.
And in terms of long-term interventions, we broke those down into two separate categories for financial and medication assistance, along with support systems and community resources. Probably the most notable for the financial and med assistance being getting Mr. Agaba enrolled in Maine Care, such as like ER coverage or Maine RX Plus, or whatchamacallit, as well as arranging pharmacy mail delivery and medication pickup assistance. And as well as support systems and community resources, most notably applying for non-emergency medical transport through Maine Care, as well as connecting to Maine Housing or Preble Street.
Hi, I'm Michelle Zuri.
Hi, okay, wonderful. Thanks so much for the presentation. I believe we have at least one of the members here on the Zoom. Do you want to give a wave? Great. Thanks so much for this excellent presentation. I'm going to open up for questions now, if anyone has any.
I got a quick question. How did you get the inspiration to create the patient case?
Yeah, I mean, I thought it was quite timely. There, Portland, it has a huge immigrant population. And I was volunteering at mini med school actually, which is part of a volunteer program with the pediatrics club at Unicom. So like going into schools and seeing how many of the kids are from like immigrant families. I just thought it was something that I wanted to see, like what kind of resources there are for people who are immigrants coming into the US. So that was one of the inspirations. And then I think I just finished my hematology section too, which is why the sickle cell patient came in. So yeah, it was a combination of what I just learned and then my experience with, yeah.
Yes, thank you.
Yeah, thanks for asking.
Great. Any other questions from our first? So I'll kind of, I really thought this was such a strong example of linking individual kind of patient care with a broader public health context. Just kind of wondering how you thought that using the FIT kind of problem-solving paradigm shaped your approach versus kind of a more purely clinical case-based application.
Mm-hmm. Yeah. I mean, I feel like the way that we are trained as just like as students who are going to be working in a clinical setting, we're very like treat the patient, kind of send them off and then treat the next patient. So I think working with other professional students and seeing how many amazing like programs there are in the community, and just even like hearing other students present in our group from like other states, just there are programs out there, and it's essential to think about where our patients are going to be after their after they're discharged from the hospital or leave our clinic. So that was incredible to learn about these programs. And it also really determines the patient's care as well, what happens outside of the clinic, and also like what brought them in the first place as well. So yeah, it's something I'll definitely carry on with me as I practice for sure.
Wonderful. We probably have time for one more question. Maybe just if you identified many barriers to care, you have one that your team thought that was most critical at first?
Yeah, I mean, we talked a lot about this. I think just the barrier of accessing like medication, whether like financially, but even just like transportation, not being able to get to the pharmacy, not being able to get to even the doctor's office. I think that obviously has a great effect on patients' outcome and preventing like the sickle cell crisis or other flare-ups. So I think that was one of the barriers that we thought could be, and there are
Yeah, I
different. Yeah,
definitely can appreciate that for
yeah,
sure. So,
yeah.
well, congratulations to your group on this and great work. Thanks everyone for joining us in this room. I think we're ready for our next kind of room to hop into, our next presentation.
Hello, everyone. My name is Mary Catherine. We are focusing on today's individual named Alex. We were part of the IPTI simulation program with University of New England. Our question that we focused on with our patient Alex was, how can an interprofessional client-centered approach improve access to care for a patient with complex medical, behavioral, and social needs? So with me, I am pursuing my master's of public health at UNE, and the rest of my group will introduce themselves as well.
Hi everyone, my name is Jake. I'm in a doctorate program at UNE as well.
Hi guys, my name is Zubia. I am currently pursuing a doctorate in dental medicine.
And I'm Maddie, and I'm at UNE for dental hygiene. So this was our patient Alex. She presented with some symptoms such as dizziness, fatigue, mouth pain, which was a major concern for her in session 1. In session 2, we mainly focused on her housing and food insecurities. We addressed her barriers for care at each session. What Alex wants out of this thing is to not feel judged by healthcare workers and to finally feel normal again. We did address her substance use with alcohol and cannabis, and some medications that she's taking is valacyclovir, which she is inconsistently using.
So within our first session with Alex, our main priority was to address her severe mouth pain and recurrent sores she was experiencing. Some barriers we found in this session included that she didn't have insurance at the time, no transportation to the health clinic. She's experiencing housing instability and some food insecurity. So as a team, our actions included, so from the dental side of things, we discussed home care for oral sores, reviewed valacyclovir use, and had discussion of substance use in correlation with dry mouth. Our nutritionist discussed the use of soft and non-acidic foods to not exacerbate the mouth pain and sores she's experiencing. In PT, we addressed mouth pain and low back pain along with her headaches, and then we discussed connecting her to resources to get her new shoes and footwear. In public health, we discussed Medicaid pathway and helping her utilize some public transportation options to the clinic.
For session 2, there was a shift in needs. So the mouth pain had resolved, so that was no longer the main concern. She was still facing housing instability. And her new priorities included helping enroll in Medicaid, access to working phone for appointments, transportation support, assisting with managing substance use, and support with grief counseling, and then mental health concerns such as ongoing anxiety, stress, and low mood. And so our team's response shifted from symptom relief to system navigation and long-term stability. And with the public health lens, we talked about the Medicaid enrollment and then those programs that we discussed earlier. And in the medical side of things, using motivational interviewing to explore Alex's mental health concerns, validate her feelings, and help her identify realistic next steps for stress and anxiety management.
Lastly, our key takeaways from session 1 was to focus on urgent symptom relief and her basic resource access. Takeaways from session 2 was to move her to a basic stability approach, making sure she had a care from all of her different supports. Some of the implications we had was working together as a team to make sure we were executing the best way of how to help Alex, as well as focusing on her chief concerns. But mostly the implications was the intercollaboration with each of her supports. But thank you. That is the end of our presentation.
Thanks for our advocacy Avengers. I think we have a member or two of the team. Will you give a wave in the background? And we love to ask you some questions. So I invite the group now to jump in and ask these experts, these advocacy Avengers, some questions. There aren't any. I'll kind of start us off. I love the title of your team. Can you maybe share an example or a specific example of an advocacy action that you proposed or kind of decided to implement as part of the project?
So, we wanted to focus more on Alex herself. She actually brought a individual with her in her second meeting, and we had to make sure we were focusing on her needs and less on the individual she brought in. So that was a core thing we did want to focus on in the second meeting because we found out beforehand, before the collaboration. And making sure we were collaborating with each other as a team, considering we had all kinds of different focuses and specialties, and ensuring that we were able to, break the cycle that was occurring with Alex because she wasn't taking her medications. She was relying on substance use, wasn't really using any of her coping skills to manage her care. So we wanted to really focus on having to better the situation and improve her quality of life.
Excellent. Thanks so much. Any other people here want to ask some questions? Right. Well, one thing that I'd love to hear your thoughts about is your experience with the IPD, the Interprofessional Version simulation, maybe how you saw a shift in your own professional identity, or did you see one?
Yeah, so starting off, just Alex coming in, her major thing was like, I want to get out of mouth pain. Like that was her like main focus. And then knowing when it came time for the second visit, like we prepared accordingly, like follow-up questions, but like that wasn't the priority. Like her priority shifted, and to be able to like know when to like step back and like realize, okay, like this is kind of out of my scope of practice. I can give her advice, but then being able to like give her the avenues to go to the right people to really like address her questions fully and just like knowing like, okay, this, I think we should talk to a physical therapist about this or nutritionist about like, you're facing food insecurity. What are some options that we can get with what you have to get like the meals that you need, or like with mental health, like talking to a psychiatrist and things like that. And overall, I like it was a really cool experience to have that kind of all there, like on demand, at that time. So that's kind of what I have to say. If you want to add anything to that, Mary.
I don't know if you have anything to add either, Maddie. Maddie's in here too. But for me, I think everyone approached the situation with their own expertise, and they each pitched in on what was concerning for the individual, especially with what she was focusing on and what she was having the dilemma with. So we each provided like a solution for each of her issues. So I think that was really helpful. Like everyone really knew, they were knowledgeable on what needed to happen and what's the next steps. And we did the research because some of us aren't from Maine and whatnot. So a lot of us were trying to focus on that aspect too. But yeah.
Wonderful. Well, thanks so much and congratulations
Okay, this presentation will be by Team 5, the gums, glutes, and guts, beyond the screen interprofessional care through telehealth.
Beyond the screen interprofessional care through telehealth. We are Team 5, gums, glutes, and guts. So our team members, Sophia, Jade, Maria, Molly, and Ashley, want to say thank you to our faculty mentors, Catherine and Marilyn, and a special thanks to Chris and Michelle, as well as our patient actors, Viva and Heather. This project explores the impact of interprofessional collaboration in providing holistic, patient-centered care through telehealth for a patient facing complex medical and psychosocial challenges. We utilized interprofessional team collaboration among physical therapy, osteopathic medicine, allopathic medicine, nursing, and dentistry to support immediate patient needs and develop a sustainable plan.
So I'll cover the background. Alex, a young 25-year-old female who did not have a place to stay, having multiple health challenges and came up with oral problems. We were from 5 different professionals: allopathic medicine, dental medicine, osteopathic medicine, physical therapy, and nursing. So session 1 was completely focused on the repo and trust building part, where we gathered the initial health data and how she's taking care of herself. And in session 2, we focused on educating Alex, working on different coping mechanisms and referrals. And our main goal is to use the motivational questions and therapeutic communication model and discuss her health goals.
Some challenges that our group faced included establishing trust with the patient through the virtual format of a telehealth appointment, as well as trying to address certain sensitive topics in the telehealth appointment, and just with our backgrounds not having received much training in this area.
Our team demonstrated several key strengths, such as using problem solving to address complex issues like medication access, unstable housing, and emotional distress. Our team communication and combination of different backgrounds helped us share various information efficiently with unique perspectives. We maintained a patient-centered approach where we were able to adapt quickly when Alex's needs or emotions shifted and focus on providing empathetic care with validation of Alex's experiences. By the end of the encounter, we were able to offer resources for follow-up care and support, showing the effectiveness of interprofessional teamwork.
Working through this case really showed us the necessity of interdisciplinary teamwork. For medicine, we learned that their role is to prioritize the urgent clinical issues. The nursing perspective helped us think about the day-to-day patient needs. And our dental team highlighted how dental issues can affect the overall health and pain. And PT added a completely different lens by focusing on mobility and quality of life. Collaborating this way made our final care plan much stronger than if any one discipline had worked alone.
Hey, is anyone from Team 5 present?
Hi, I'm Molly and I'm from Team 5.
Hi, Molly. Great presentation. Is
Thank
any of your
you.
other teammates here as well?
I believe I'm the only one who was able to make it today.
Okay. So, does anyone in the audience have any questions for Molly? I would like to ask you something, Molly. Can you tell us like one thing that you took away from your experience with this IPD and working with your team?
Of course, I think one of the biggest takeaways for me was just throughout the experience itself, getting to understand more about compassionate care for patients. One thing I really was able to learn from my teammates was just how to approach a patient in a way that gets to the point, but is very respectful of their time being here, because the setup for our case was a telehealth appointment with the patient. And even through that virtual setting, I feel like I was able to learn a lot about how to approach the patient when they're not there in person with you. For example, during our first initial meeting with the patient, my teammates made sure to thank our patient, her name was Alex, but to thank Alex for taking the time out of her day to showing up and acknowledging how that's such an important step, and acknowledging that she does need help, has concerns, came into the office, because for a lot of patients, that's a big barrier and it can be scary to go see a health professional. And hearing them be so respectful of her really inspired me throughout the rest of the program to try and speak to the patient in the same manner. And even at the end of our first appointment, planning for the next appointment, acknowledging
how grateful we were that she was feeling open to sharing with us, making sure that we asked Alex before we asked her sensitive information if she was okay sharing it. And then in our second meeting, like second telehealth appointment with Alex, we had another patient actor who was serving in the role of her friend who was also joining the call, and being sure to ask Alex if it was okay that we spoke about the sensitive topics with her friend there, making sure that she still felt included even if the friend was talking because it was her appointment. So I would say that was probably my biggest takeaway, and something I'll definitely try and apply when I'm speaking to patients in the future is really acknowledging their pain, their experiences, and how much effort they've taken to get there. And it was really cool to see all of that being used through our group, because that's something we'd previously learned about motivational interviewing and trying to inspire the patient to share more with you. So it was really great to be able to apply a bit of what we've learned, but then take so much away to be able to apply in the future as well.
Any comments to what Molly just said? Well, I would like to ask you, do you feel that your respectful language towards the patient created a trust that wouldn't normally have happened if you didn't speak to the patient that way?
I do think, especially in our case, it created that trust. I think in any situation, it's important to be able to be respectful to the patient and build a level of trust they feel comfortable communicating with you. But our patient specifically was very mistrustful of the health professionals. She hadn't gone to a health profession office in quite some time, and you could tell that she felt like she was initially holding a lot back because she felt like she would be judged for certain things such as an overuse of alcohol, how she'd been coping with things, even just different medical conditions. So I think being so respectful of her really made her feel more comfortable in opening up and being honest about her healthcare with us. And it definitely set a good tone for the environment. And I think even just amongst the health professionals in the room, it made it easier to feel comfortable asking the patients things because you knew that like none of your teammates would be judging you, and that you knew it was like a safe space to be asking the patient these.
Sorry. No, it sounds like you had a great time with your teammates and you had a great experience with the IPD program. So thank you so much for coming in here today to help present what your teammate did. So welcome to Team 3's Compassionate Croissants presentation on addressing complex social needs and interprofessional team approach.
Hi, my name is Lauren Klein. I'm a third-year physical therapy student in UNE's DPT program, and my faculty advisor for this IPTI interprofessional experience was Dr. Marissa Lyon. Today, our team will be presenting on addressing complex social needs through an interprofessional team approach.
And my name is Elizabeth Davis. I'm a second-year medical student at UNE, and my faculty advisor for IPTI is Dr. Chris Robbington. Our team for this project was physical therapy with Lauren Klein, occupational therapy with Isabella Raposo, nutrition with Danielle Henry Plummer, and then we had 2 medical students. There's me, and then there's Miriam Mindell with Tufts Medicine.
So our case looked at a patient named Alex with many complex psychosocial factors, an inconsistent history of medical care, and lack of access to resources, who recently had experienced acute medical symptoms leading to multiple ER visits. Our goal as a team was to collaboratively address the complex needs and individual values of our patient as an interprofessional team.
And from the case, we learned that different healthcare professionals think about the same case in different ways. This created well-rounded care with the patient at its center. Shared goals throughout the team leads to better patient outcomes. One primary focus for the team can improve efficiency and quality of care. And then we found that a team is better equipped to address complex social needs rather than one individual. So this utilizes the personal strengths, knowledge, and resources of each team member to address unique patient needs and facilitate meaningful change.
So what we will use moving forward in our own individual professions are active listening and recognizing limitations of our own knowledge within our individual fields. We will consider all input when determining a patient's care, recognizing our own bias and having an open mind about different treatment approaches. We will also utilize the one size doesn't fit all to recognize that it is important to meet patients where they are. So many of our patients may have complex social needs in the future, but they may not be ready to change at the time that we see them. It is important to empower the patient to take initiative and use salience to guide our treatment approach to make sure the change is meaningful to the patient. Thank you for listening to our presentation today, and we hope you enjoyed.
Thank you so much. To Team 3. Is anyone from Team 3 present?
I think it's just me.
Okay. Great presentation, Elizabeth. Thank you so much. Does anyone in the audience have any questions for Elizabeth? Well, I have a question. So in your team, it looks like you had 4 students from 4 different health professions. Was there a health professions that wasn't part of your team that you felt that you should have had and needed?
100%. I really felt like I could have used a social worker. Pretty much every meeting we had, we discussed how we really wished that we had a social worker to kind of bring everything together, because we identified problems in the patient's life, but then didn't really know where to give them the resources to fix those problems. So yeah, we really wanted a social worker. And I think dental as well was one that we were really hoping for.
What do you think you learned from one of your teammates?
I learned a lot from my teammates. It really surprised me how different everybody approached the case. A really good example is the nutritionist on our team. So as a comms student, we really only learned to just ask about the patient's diet, and that's about it. But the nutritionist thought about things I never even would have imagined to ask, like who are you sitting down to eat your meals with? Where you're storing your food? Do you have room in the refrigerator to keep your food? What do you do when our patient had transient housing? So what do you do with food when you don't have somewhere to stay? Whereas all I asked about was, what does your diet look like? Do you eat vegetables? Do you drink alcohol? Do you drink caffeine? So it was really interesting to, see how much questioning you can get when you take it from a different approach.
So it sounds like you learned that the environment is just as important as just, treating the physical symptoms.
Mm-hmm, exactly.
Any questions for Elizabeth from the audience? Well, I liked how your group came up with the quote, one size doesn't fit all, right?
Mm-hmm.
So I think it's really important to know that sometimes your patients aren't ready to change. It's not necessarily that they're a bad patient, but they're just not there yet. And it's so important to just continue to create that trust by speaking to them respectfully, acknowledging their struggles, and just being there for your patients.
Definitely. I felt like there were some things that I really wanted to focus on, and the patient didn't seem too interested in focusing on those aspects of their care. And it was really hard to let go of that and focus on something else that the patient wanted to focus on. But the meetings became a lot more productive once we did that.
Thank you so much, Elizabeth. It was a great presentation.
Hello, my name is Destiny, and my partner Haley and I are going to be discussing how the elder teacher perspective and how aging impacts care. So we interviewed an elder teacher who we'll call Mrs. P, and she lives in a retirement community with her husband, Mr. P. And this experience was to just focus and strengthen our clinical interview skills for patients within Mrs. P's population. I'm a physician assistant, as well as Haley is going to be a pharmacist. So we're both future healthcare providers. With Mrs. P, she emphasized how location really impacted her ability for her and her husband to reach care, especially because her driving ability changed or has changed over time. She really noticed this when she had her hip surgery earlier this year, because she is the primary driver for both her and Mr. P. She found that was a barrier that she experienced and continues to experience as she matures. Additionally, she noted that by having hearing aids, if she doesn't have them accessible, that also impacts her ability to understand the world around her, including in the healthcare setting. The support system that she emphasized was both inside the retirement community as well as outside. Services such as grief counseling and activities with other residents like Dominoes and book club really helps with the mental well-being of both Mr. and Mrs. P. Additionally, having access to healthy foods through their cafeteria and exercise classes for balance was really essential for them as well. I'm going to hand this over to Haley and she'll continue from here.
I'm Haley. I'm a third-year pharmacy student. I'm just going to be talking a little bit about my experience visiting our elder. So to start, I'll just talk about the medication labeling challenges that we noticed. Our elder was recommended to take Voltaren gel for arthritis by her provider, and this was something she talked about to us. She hadn't used the medication yet because she had trouble reading the instructions, so she asked us to further explain it to her. As you can see, the package instructions are very small, and because of the size, you can miss some of the important cautionary information, and not being able to read them at all might cause you to take it incorrectly or skip your dose altogether because you can't read the instructions. This medication is different from other medications because it's a gel. So as you can see in the corner, it shows you how to measure out the gel, which is not as simple as just taking a pill. This was something that we noticed was important as providers, just to make sure that we're taking the time to explain to our patients how to take an over-the-counter med and recognizing that there's not always someone at home to explain. Another barrier to care that we noticed was cost. So her and her husband were recommended to take these eye vitamins. The dose is 2 pills per day, but because of cost, one bottle is up to $30. They couldn't afford that, so they kind of alternated between 1 and 2 pills. So financial limitations are another thing that can affect adherence in aging populations who take multiple medications. So as providers, just looking for ways to lower the cost or help with that is important. And that concludes the end of our presentation. And thank you for listening.
Is Haley or Destiny here?
Hi, everyone. Haley is not able to join us today, but I'm more than happy to answer any questions that you may have.
Okay, thank you. It was a great presentation. Does anyone in the audience have any questions for Destiny? Well, I have a question, well, more like a comment. I noticed that in one of the slides, it stated that the providers need to explain the medications. And oftentimes I think providers just say, oh, go talk to a pharmacist, right? Because they're the drug expert. So why did your team decide to put providers and not necessarily the pharmacist?
I think that it's important as providers to constantly expand our healthcare acumen. So, in my training as a physician assistant student, we're being told and basically expected to know specific side effects of certain medications, and it can help provide basically more holistic care for patients. We decided to put both myself as well as Haley in this specific scenario because it gives the patient basically more opportunities to hear the information, meaning that they'll be more likely to understand and retain it in the long term.
It's a good way to reinforce from what one provider says to the next provider.
Exactly. But definitely utilizing our pharmacy colleagues is essential, especially when it comes to all the different mechanisms. They are truly the experts.
And the over-the-counter medications, there's just too many to remember, to be honest.
Absolutely. We just do our best.
So was there one thing that you felt you learned from your elder patient that you wouldn't have necessarily learned if the patient was younger?
I do. I find that with the elder teacher experience that we had, she really appreciated us just actively listening. I remember we had multiple visits with our elder teacher, and I remembered, I believe it was her son's name, and she felt very heard and very impressed with that encounter because it showed just overall care for her as a person. And I think that if the patient was younger, they may have not picked up on that, or they may have not felt that that was like as strong of an indicator for not only our active listening skills, but like our ability to understand her and ensure that she felt heard, essentially.
I know that you listed the support system, and one of them was resources. How difficult did you find that the resources availability for the elder patients?
For our specific elder patients or elder teachers, they are very fortunate in the fact that they live in a retirement community that has access to a lot of resources. So, all the resources listed were actually community events put on by other members within that community, such as the grief counseling, exercise classes. She actually is also, I call it a welcome wagon. So, she helps to connect other people who are new residents on her floor to those resources. So, for this specific instance, the access to resources wasn't as much of a problem as it would be had that person been in a different setting.
Harrigan, did you have a question?
Yeah, do you and anyone who I guess works more with patients can answer this too. Do you think that there is a sort of barrier in wanting to ask for help with your medication and the prescriptions that are given to you? And if there is a barrier in asking, do you think that we see that more from an older population or from a younger population?
It's a really good question. To address your first question, we did actually run into this with our elder teacher. She did ask us for help with the Voltaren gel, but it wasn't because of a lack of wanting to understand or know how to apply it. It was more of she had other questions that were addressed during that visit. And I think that that can happen specifically with more patients with more chronic conditions or multiple conditions because the waters can get really muddied and it can be very difficult, especially when you have such a short time slot to address all the patient's concerns to make sure that all of those questions are answered. I do think that it can happen in younger patients, but I think that because as we mature, we tend to have more chronic health conditions, it tends to present in patients in more of a elder population.
Thank you so much, Destiny, for your great presentation.
Thank you.
Welcome to the FIT training, Public Health Problem Solving Paradigm in Interprofessional Team Training. This is the FIT Team 3.
Hi, our team's project was Social Determinants of Wellbeing, a Complex Case. Our team members included myself, Molly, Megan, and Emily, and we would like to give a special thanks to our program directors and the various presenters we had throughout the program. Our team was tasked with creating a case study examining the social determinants of health and applying the public health problem-solving paradigm to a patient we've created. We then developed a patient-centered framework and identified corresponding interventions. Here is what our framework looked like, and we utilized teamwork in various ways to take knowledge that we learned from our programs and outside resources to apply it to our patient in creating our framework. Our patient was Terry, a 42-year-old woman with active tuberculosis and several other conditions and contributing factors who is currently unemployed and unhoused. Our team identified various organizations and potential interventions to assist Terry in addressing her health concerns, finding reliable housing, and accessing care. A challenge our team faced in generating the case was finding the right balance of realistic barriers to care and patient background factors, while also being able to reasonably address the various needs of the patient with our skill set and current knowledge. Our participation in this program allowed us to learn more about how interprofessional care is essential in providing care to patients with complex backgrounds and health concerns. We were able to gain interprofessional communication skills, as well as learn more about the understanding and addressing patient needs through a public health lens while considering the social determinants affecting a patient's health. We also got the opportunity to work together as a team and learn more about how our different educations and programs can all factor into providing care together.
Thank you. Is there anyone from Team 3 here? Emily, Molly, or Megan?
Hi, I'm Molly and I'm here, and Megan's also on our call.
Okay. Thanks for being here. John, do you have a question for Team 3?
I do. I'm sort of new to the jargon about social determinants of health and was wondering what was meant by finding a balance of social determinants of healthcare in regard to this patient profile.
So throughout the program, before we began developing our case, we actually were able to have some presenters come in to educate all of our team members more on social determinants of health. But in that sense, we just mean the different aspects of somebody's life that's not necessarily medical that relates to their medical health. For example, if it was just their medical health, we'd be looking at different conditions they have. Whereas with the social determinants of health, we're also looking at, are they able to afford their appointments? Can they transport themselves to their appointments? How does their social interactions and support systems affect their health? And then during the presentation, I mentioned how our team had a bit of a hard time finding the right balance. And by that, I meant in developing the case, we had free reign to input whatever conditions we wanted, whatever social health, whatever transportation factors. And initially, our team went full in. We had plenty of different barriers to care. And then as we started to workshop it with our program directors, we realized a lot of these different barriers were interacting in a way that would make our case incredibly hard to get to the interventions for. So our faculty recommended that we consider altering some of the determinants of health or some of their conditions. So we ended up taking out one of their conditions, adjusting some of the determinants of health. That way we could more adequately make the case and come up with interventions for the case.
Thank you. That was helpful. But I imagine that in reality, many cases do have so many of those complicating factors that it seems impossible to be able to allow, practitioners to get access to the things that a client needs. And then maybe you might have to pick which one is the first or most important.
Definitely. And I think learning how to prioritize that is incredibly important. And I actually think for myself, and I'm speaking for Megan and my other teammate Emily here as well, but that's one of the main takeaways from getting to participate in a program like this is being able to understand how we might need to look at those different factors and figure out how they interact, because it can seem very daunting when a patient has lots of different factors that you're trying to address to provide the best care. So getting a little taste of it now is definitely helpful before we go on fully to trying to treat patients ourselves. That way we can better help them in the future.
Yeah. Thanks for your explanation.
Molly, was there a health professions that you wish that was on your team?
I think one profession that would have been helpful is definitely social work. I think they definitely would have been able to help a lot with the interventions and just figuring out what some of the priorities would be for addressing our case. My team was myself, and I'm a dental medicine student, and my other two team members were College of Medicine. So we had a lot of experience in figuring out what medical conditions we wanted to address and in understanding what some social determinants of health are, but figuring out how to find the right programs that could help, how to integrate the programs or make them available to the patient. It definitely would have been helpful to have a social worker, just because I feel like they have a lot of training in figuring out how to make the patient's lifestyle align with actually applying the programs. Whereas for us, it's more just providing the programs. But at least now in most of our training, we haven't had too much experience in figuring out how the patient might be able to integrate the program.
Can you talk a little bit about your experience working with your teammates?
Sure. I had a wonderful experience working with my teammates, and it was definitely great to be able to get to work. One of my teammates was a first year medical student, and one was a second year, and getting to learn more about their education and how their program trains them, as well as just the differences from what you learn in the first year to the second year, really made it so that all of us could bring different knowledge and background information to the team. And it was also great because everybody, especially in choosing to participate in a program like this, did have a very collaborative mindset and was very open to trying new things, understanding how we can bring things to the table, but also take a step back and learn from each other. And I think that was very valuable in not only getting to experience working in a team, but especially working in an interprofessional team, especially because for all of us, especially in my role as a dental student, we will be interacting in the future and looking for referrals, looking for other advice. So getting a taste of that experience now has been very helpful in feeling more comfortable looking to do that in the future.
Well, thank you so much, Molly, for being here to share your experience with us. Great presentation. Welcome to another FIT presentation from Team 2, Interprofessional Care Interventions for George Lavoie.
Hello, today we'll be talking about interprofessional care interventions for our sample patient, George Lavoie. My name is Jordan, and I'm a first-year College of Osteopathic Medicine student. We also have Kerrigan, a second-year comm student, Anya, a social work student, and Newman, a pharmacy student. Our goals for today will be to look at George's transition from acute to community-based care, identify structural and biological barriers, and look at some interventions. In short, George is a 46-year-old HVAC technician who fell ill with Legionnaire's disease after a fishing trip. Due to having significant comorbidities like tobacco use, chronic diabetes, and unstable financial status, George ended up with prolonged and severe illness.
When George is discharged from the ICU, our goal is to support a safe and smooth transition back to his daily life. We'll connect him with a sliding scale PCP who can simplify his medication regimen, help manage his chronic conditions, and put him on track with preventative care. We'll also collaborate with Healthy Homes Maine to ensure his home environment is safe and supports his recovery. Beyond his medical needs, it's important to strengthen his social and emotional support. We'll link him with community programs that help him meet people with similar interests. This can also increase his physical activity and provide outlets that can help improve his mood and reduce the symptoms of depression that he faces. Together, these steps will promote a faster recovery and set him up for long-term success.
Hi, everyone. I'm Anya. I will walk you through a couple of slides on policy and occupational support for health policy and insurance navigation. One intervention is to help George navigate the ACA marketplace to ensure coverage for chronic conditions, annual wellness visits, and ongoing medication management. Of course, this is done in the context of some policy uncertainty around subsidies due to the recent DC shutdown and a pending Senate vote in December. For occupational support, we're proposing engagement with the plumbers, pipe fitters, and HVAC technicians Local 716 to help George secure safer work conditions, peer support, and explore vocational or occupational therapy for back pain. And with that, I will toss it over to Newman.
Thank you, Annie. For George, we focused on simplifying his medications, improving affordability, and making the transition home safer. We discontinued high-risk drugs, streamlined his regimen, and connected him with cost-saving resources like the 340B options, Med Access, and the Maine RX Plus discount card. We also synchronized his medication, reinforced his vaccination, and planned a follow-up visit to support adherence. At home, we provided a simple color-coded chart and used a teachwork method to reinforce understanding. In summary and conclusion, this case shows that interprofessional collaboration is ideal for optimizing patient recovery.
I think all four of us are. Oh, great. Great. Does anyone in the audience have questions for the team? I have a question. So your team discussed advocacy and insurance. What made you go along those routes, and how difficult was it for your team to find the information that you needed?
Of course I was. I can take that one if you guys are okay with that. So I think, well, first off, there's just so much conversation about the ACA marketplace subsidies. And we had this patient with very complex patient, all these comorbidities. And it seemed that if we were going to start to plug him into the health system, that we were going to need to be thinking about affordability. So realizing this is a question you didn't ask, that because there is uncertainty around the subsidies, and he might be a good candidate for that, that we would absolutely have to have a backup plan, right? And sort of manage his expectations around that.
I think going into that too a little bit, we really wanted to get him involved with his community. So like getting him in that local union, because working in the union, he may be able to get a little bit more insurance coverage or just more understanding around what's out there.
Can you talk about the advocacy that you mentioned in your presentation?
Can take a little bit of that. So I think as far as advocacy goes, for me, this patient spoke a lot to like what I've seen before in healthcare and what we will see as future healthcare workers. And I think advocacy really does start from the grassroots. So when you have one patient that you're seeing is struggling with something, you're going to have other patients that are encountering the same things. So having the ability and like the power in a healthcare role to kind of hope for that advocacy and try to make their lives a little bit easier is something that we kind of looked into.
So it's a good idea now, right? As students, for you to advocate your patients, and you can take those skills and knowledge as you move through your medical journey, right?
And
Go ahead, Kerrigan.
yeah, going off a little bit of what Jordan said, what was really beneficial for this case too was his supportive brother, who we didn't get to talk a lot about in the recording. And so this patient had a very supportive brother who was willing to sort of be his advocate and listen to like all of the different interventions when George was in the ICU. So I think it's a good lesson too that we can utilize family who's willing to learn, because the more ears that hear it is going to make the outcome better.
It's a very complicated case, and there's not a lot of time to discuss it. Is this a real person or is this a fictitious case? Fictitious.
It's a fictitious, yep.
What do you think the likelihood is for compliance across the board with all of your recommendations?
Sort of judging off of previous healthcare experience that I have, as well as sort of looking at all of these different intersections that this patient is facing, getting, 100% adherence across the board is probably pretty slim. But the goal is that if you can start with a little bit of making just adhering to the plan easier, the symptoms and the disease, like morbidities, will get better over time, which will allow more adherence as time goes on.
Yeah, I like that thinking. I'm an occupational therapist by profession. I've worked with a variety of populations. And if one part of your plan worked, it's likely that that person might think about doing one of the others, and having some compliance. And which one would most likely make him feel better or feel more in control of his situation would be the key. And if it could be easy to do. Smoking cessation is, that's probably the last one. That's going to be pretty hard. Seems like he's a lifetime smoker, and but success in a couple, might really lead the way to others.
Just to riff on that a little bit, I think focusing specifically on what it is that the patient is focused on, or in this case, his brother, what he cares about, and then also utilizing methods such as the teach back method. Like, how well does George or his brother, how well do they understand the regimen, right?
Mm-hmm. Yeah. And it's likely the time in the ICU scared the living hell out of him. And his probably number one mental is, I don't want to go back there. I don't want that to happen again. So what part of your plan might be the one that would be the first to offer as a fail-safe of preventing it? That would be, you'd have to sit down and think about that and see what he'll buy into too.
Well, thank you so much to the teams for sharing their patient cases and their experiences and what they learned from one another.
All right, so I think we're ready for the first one. So this is from one of the FIT teams, asylum-seeking female with newly diagnosed HIV. Let's get rolling.
Hello, we are group 7, and our case is asylum-seeking female with a newly diagnosed HIV. My name is Loy, and I'm here with Dalton, Jasmine, and Julia. The team synthetic case focuses on a 30-year-old female who immigrated alone from the Democratic Republic of Congo. She's in her first trimester of pregnancy and recently learned she has HIV. Given her delicate situation, the best methods to address her needs are through an interprofessional lens, including osteopathic medicine, nursing, and public health.
This is our framework, and it's used to visualize the different risk factors such as biological, behavioral and psychological, demographic, and socioeconomic factors that influence our patient's health. This will help us to identify interventions that will help support our patient.
The protective factor, our patient was recently diagnosed with HIV. Since she is pregnant, she is very motivated to keep her HIV undetectable using antiviral medications to reduce the risk of vertical transmission to her baby.
The first intervention we wanted to address is her access to medical and prenatal care, as well as her support for her HIV diagnosis. The two organizations we identified help to provide primary care, prenatal care, HIV testing, treatment, case management, as well as financial assistance for medications, labs, and support. We next wanted to connect her with housing support. The two organizations we identified help to connect individuals with emergency, transitional housing resources, as well as access to food and a permanent living place.
Food insecurity is common among recently arrived asylum seekers due to limited income and cultural food preferences. Organizations like the Good Shepherd's Food Bank and the Bangor Area Soup Kitchen provide free or low-cost meals, ensuring adequate nutrition to our patient during her pregnancy.
For this slide, what really stands out to us is her underlying PTSD, anxiety, and depression. With everything she's going through, we want to connect her with NAMI Maine and community health and counseling services. These places offer trauma-informed support, counseling, and a safe place for her to process everything she's navigating. Here's a quick summary of the interventions we discussed. Together, they provide well-rounded, culturally responsive care. We also included the Immigrant Resource Center of Maine for language support and Maine Care non-emergency transportation to help her get to appointments and stay connected throughout her pregnancy. Thank you so much for listening. Our group hopes you've enjoyed our presentation.
All right, that's really great. So anyone on this team, if you want to raise your hand, so we know who are we asking question to. And please feel free. Now it's your time for questions. All right, I can start out, and then maybe when you guys are thinking about other questions. So this is a really unique case. The patient is a recent immigrant. How, I guess, while you were thinking about intervention, how hard or how easy did you feel it's looking, finding resources for this patient?
Yeah, I guess I can start, and then Loy, you can jump in if you want. So I don't know if anybody's familiar like where Bangor, Maine is, but it's about like 2 hours north of Portland. It's rural Maine, I guess you could say. And in the news recently, there's been a lot of public health changes up here. So a lot of like urgent cares have been closing due to money, but also like testing centers to check for HIV. The food programs up here, they also are only open certain days out of the week. So I would say it's been very hard to find resources up here due to like limited access.
And also, I've worked a lot with refugees, and so it made a good connection with both the homeless and the lack of resources available, and with refugees who are struggling to find a new home and get acquainted with the new area.
So knowing that, what's your next step?
I would say definitely advocating to get more programs like in these rural areas on the part that I was talking about. Just advocating and like knowing the importance of checking for HIV and getting under antiretroviral therapy pretty quickly, making sure, especially where she's pregnant, making sure she has a warm, safe place to be during her pregnancy and that she has adequate nutrition. So a lot of different advocacy, I would say.
Yeah, especially where we recently had the shutdown of SNAP. It was a big impact on refugees and other people who depended on that program. So advocating for sure.
Great. What I like to hear.
So the question is, how do you feel this experience will influence your future practice? Yeah, I guess that is a very good question. I think for me, I am in medical school, hopefully wanting to go into pediatrics right now, and I want to stay in Maine. And there's definitely a need for healthcare providers in Maine. So just knowing where, there's some disadvantages for some people, I think I can like swing my focus and try to focus on that. and make sure like there's equity in their healthcare as much as possible. Um, yeah.
There's another question coming up. You guys want to respond?
The question is, does this motivate you to want to do work or do clerkship in a rural setting? Yeah, so I'm in my third year right now, and I'm actually up in Bangor right now for the whole year. And it's been a very good experience so far. I'm seeing a lot. I get patients from up in Presque Isle, which is, 2.5 hours north of Bangor. So they're coming into the emergency room, or needing emergent surgery when they get here. So, yeah.
I'm in public health, and with my work with the refugees, I really want to go global health and go to these places where people lack resources to help them receive the resources they need and direct them to treatment. And so, yeah, this is a good project for us.
Yeah, this is great. I hope this is not going to scare you away from a rural area, but really, thinking about what we do need for a rural area for the population. All right, so this is also from a FIT team, from another team. So the title is A Patient-Centered Approach to Pediatric Asthma Management.
Hi, this is Sab. We are from Group 5, and we are with the Fall 2025 FIT program. And today we are going to talk about asthma management. So this is a patient-centered approach to pediatric asthma management with Layla, Jenna, and Sabrina. And our objectives are history of present illness. So our patient has a history of asthma, and then patient-centered framework, as well as we're going to go over the interventions that we are going to apply to help our patient. So Olivia O'Brien is a 9-year-old in rural Maine with moderate persistent asthma. She struggles with nighttime coughing and wheezing, and it is often triggered by the environment. Her home has has a problem of mold since it's an older rental property, so it doesn't have great air quality. And some of the barriers that she and her family experience are that they have limited transportation, so there isn't a great public transportation system. And then also her parents' work, they have pretty intense work schedules. And also, the impact of her illness is that she has to miss a lot of school due to her diagnosis, and it causes a lot of anxiety for her because she does not want to miss a lot of school. So, yeah.
And then this is kind of just an overview of our entire project and all of the different protective factors and risk factors that go into Olivia's care. I'm not going to go super in depth into it just because we don't have a lot of time, but some of her protective factors over here are her parents are willing to do a lot of different things for her. And then our risk factors are divided into different groups. So whether that be her health status, different behaviors, and then the working and living conditions. And something that's notable for Olivia is that her risk factors in the working and living conditions make up a lot of the risk factors here for her, and is what we focused a lot of our interventions around.
So we're going to move into the interventions that we have for our patient. Again, I'm not going to go too much into depth about the interventions, but basically we classified them according to our patient's care needs, resources that are available in the area, and then what we thought a good intervention would be. Some of the notable ones were asthma education and self-management. So we suggested the open airways for schools, which basically teaches patients how to use their inhalers, and it helps with action plan updates. And then another key thing was ensuring that there was digital access. So community Wi-Fi hubs and local libraries could play an important role in making sure that not only the patient, but also the parents have access to online education, in addition to some of the other ones that we have listed.
But that is our work, and thank you.
All right, lovely. Anyone that has questions? So again, we're in the social driver health room here.
Hi, I'm with this group. I saw that there's a question in the chat about it being feasible to homeschool Olivia. And that is something that we talked about, but one of the biggest kind of drawbacks that we had for that is they are in Bangor. And I think like the previous group said, is a more rural area. And one of our kind of drawbacks from that was the social factor of her development and the fact that she likes going to school and wants to be in that environment. And then another addition to that was just unstable Wi-Fi conditions. So I'm sure if there was something that we could get to them that would help with that, that could be an option. But just in this case, it seems like she does want to be in that school environment and enjoys having that as a part of her developmental process.
And this is Sab. I just wanted to add that also both of her parents work, so it would be really hard for her to even be homeschooled. Like she would need to her parents would have to find somebody that would be willing to even come to the home, even if they did have that Wi-Fi stability. Sorry, I will do that.
So there's a question in the chat.
So the question is, if the house contains mold, is there a separate place to school her? So right now she does attend an in-person school, so that's kind of where we were going with that. And because the house contains mold, some of the resources that we found were able to kind of collect funds in order to help them solve that issue, or to one of the issues that they were facing was that the landlord was not being responsive to their requests for fixes. So they have different resources for different lawyers or other legal means that could back them up during that. And then we didn't specify how far her school was in the case, but that definitely could play into a factor of her parents' ability to like get her to school, and also if she needs assistance in like medical care during that time, in different people's abilities to reach her during that time if the school nurse is unable to help her.
I have a quick question. A lot of your interventions actually involve partners that's not in the traditional clinical care. So like the schools and the internet, the library, housing. How do you think your interprofessional team practice, this experience to help you to navigate that, to actually get something done on that list?
I think it was interesting for me, at least, just because I'm in the dental program. So we don't focus a lot on asthma care specifically, but it was really interesting for me to look outside of that and see what resources that even I could offer to potential patients, just because oftentimes we see patients more than a traditional care doctor would. I'd be interested to see, I know Sab is in the social work program, so I'm not sure if she has a different take on that. But
yeah, I was gonna say I'm in the social work program, and so I think partnering with the school, like usually the schools have social workers that you can partner with, or at least starting with maybe the school counselor. A lot of times those school counselors are social workers, and just getting in touch even with potentially a caseworker or someone that does care management that could utilize a lot of these resources that aren't part of the traditional clinical side of things.
Mm-hmm. That's great. I hope the program will give you guys some tools, getting more brave to get out of your comfort zone and start talking to people in different areas, different sectors, and start a collaboration. All right. So this is a very interesting title, Heart. So healing everyone and restoring trust.
We are Team Heart, a multi-professional group addressing together the needs of our patients.
Alex Simpson, our patient, came to our clinic presenting with dizziness, fatigue, sleep disturbance, and regular cannabis and alcohol consumption.
This is the case of Alex Simpson, a patient in their 20s to 30s facing social and financial challenges that have worsened his overall health. Our interprofessional team aimed to improve his stability, nutrition, and mental well-being through coordinated holistic care.
I'm Miju, a public health
is to connect Alex to community internet and phone resources.
In my role as a generalist, I approach Alex's case from a whole person perspective, linking his physical symptoms to underlying social and emotional factors.
From the physical therapy perspective, I provided motivational interviewing regarding alcohol consumption.
From a nutrition standpoint, with Alex, we focus on managing resources, cooking and feeding himself with reduced resources.
I'm Nancy Shrestha. From a psychiatry standpoint, from medicine, we worked on building trust and rapport with patient Alex and his friend Bobby. We validated feelings as well as showing empathy after the loss of his recent brother. My focus was on psychiatric concerns, including depression and anxieties, making sure that patient is supported from a social standpoint and using a biopsychosocial approach. We also talked about treatment management, which includes medications, treatment, with therapy and support groups.
Through a nursing lens, I identified any ADLs, addressed Maslow's hierarchy of needs, looked for gaps in the social determinants of health, and created an action plan with the patient while maintaining patient dignity. Through our interprofessional simulation across over 5 different professions, we were able to provide the utmost quality care plan. In each session, with and without the patient present, we collaborated as a whole and brought our own perspective to the case. It's important to listen to your future colleagues to provide the best patient-centered care. Team Heart used Zoom to our advantage to present the information in an effective way.
Thank you. A special thanks to the patient actors, Sergio, Renders, faculty, and facilitator for their support during our APT experiences. Thank you and your questions.
This is great. So, Team Heart, if you want to identify yourself.
Aye.
All right, so feel free. This is the time for questions. And I can start with a question here, because in your title, Healing Everyone and the Restoring Trust. So can you elaborate on the restoring trust part of your title? How does that, help you with the patient care in this case?
We wanted to establish trust with Alex because he was very shy at first and his camera was not on when we met with him. And we wanted to build trust with him to be able to have him be able to give us information that we need to be able to best create his patient care plan. Anything else to add, Michaela?
Yes, additionally, Alex, he has missed a few appointments. After he missed a few appointments, he's out of the program. But we wanted him to come back and to restore the trust in his care team.
That's actually part of my follow-up question. How can you make sure that he will be in compliance with all the, treatment plans that you kind of set it up for him?
I think companionship will be one of the main things. Walking along Alex and his friend Bobby, who he's currently living with, I think that will help a lot in making sure that he's compliant with all of our recommendations and follow-ups. Zisha, I don't know if you want to add something.
No, yeah, that was exactly what I was going to say too, for sure.
You got quite a good comments in the chat. Anyone else have questions? I can ask him more questions. Chris, do you have a question?
I was just going to ask them to expand on how they were able to synthesize their different professions into a care plan for Alex, if they could expand on that a little bit.
Alex was a complex patient that presented with a variety of different issues across different healthcare fields like nutrition and social work, psychiatry, nursing, and we were all able to pick up different deficits of where he was lacking and kind of collaborate to create the best care plan because each profession really was able to identify an issue and work on that together.
And additionally, it's also true that we were able to build upon each other's knowledge, and we were able to come up with a care plan for Alex that is really comprehensive and very round and patient-centered.
I think this will be a great case of our FIT program as well. Are there any other questions? So I was just wondering about, you guys must have heard about our trauma-informed care. Have you guys take advantage of that, approach when you approach to Alex?
When we interviewed him, we kind of used therapeutic approaches, especially because he was a little shy at first. Like I said, the camera was off. He seemed apprehensive. Especially for therapeutic approaches that I've learned in my nursing courses, we were able to kind of get more information out of him more gently.
Upon our second meet with Alex, he did have someone in his family passing away, so that is something that we were also able to implement in this particular case with something that was very fresh and very traumatic. So as DJ mentioned, we were able to gently create a connection with him for him to be comfortable, also not only sharing what happened, but also feeling comfortable with us as a team.
People are moving in and out. So this is a social driver of a health breakout room. Feel free.
I have another question, which is, who did you wish was on your team who wasn't represented on your team?
Oh, I think pharmacy will have been really great because we didn't have, and there were some interactions between medication that he was taking and his cannabis use. So I think having a pharmacy professional will be very beneficial.
So hopefully through the program, you learn some tools you can reach out to the pharmacist. I want to hear some people representing the FIT team and then to give them perspective. I don't think your team has a public health representation here either, right? Wondering if Eloy, are you still available? I know you're from public health. You could give us some input from yourself, your experience.
I'm sorry, I will add to that. Some of the things that we did discuss with public health related and social work was trying to get Alex a job. For him, he did have some experience in grocery store. So we thought that trying to connect him with different grocery stores in Maine where he lives will also be beneficial.
This is interprofessional collaboration in sickle cell anemia.
Hi, everyone. We're FIT Team 1 at UNE. FIT is a program on adopting public health problem-solving paradigms and interprofessional team training. The main goal of this was to look over a case, and overall the case highlights how an interprofessional model supports more holistic, patient-centered care and shows the impact that effective collaboration can have when managing challenging health situations. Our case is a 37-year-old Spanish-speaking woman from the Dominican Republic who lives in a shelter with her 3 children. She was diagnosed with sickle cell anemia with recurrent vaso-occlusive crises and is currently using the ER as her main source of care. Her history also includes alcohol use disorder, functional asplenia, and worsening renal function.
And here's the framework we developed and worked off of to capture all aspects of our patient. In terms of interprofessional collaboration, we considered a holistic understanding, mutual learning among team members, a use of shared language within the team so that we could collaborate effectively. We also took an equity and justice focus that we felt was really important. And finally, we determined if our goals were feasible and aligned.
For our collaboration began by jointly identifying the most pressing issue, her health, in the context of unstable housing and limited access to care. Each member analyzed the case through their disciplinary lens and shared insight to construct a cohesive framework and interventions. Leah and Maddie identified clinical needs, I assessed feasibility with food insecurity, and Stel layered this with a broader social and policy structures. Regular discussion ensured that each domain informed and reinforced the others.
For our group dynamics, we found it challenging to cover both medical detail, nutrition, and public health policy without oversimplifying any of these aspects. We worked together to build bridge together clinical terminology and public health concepts in our final framework and proposed interventions. And we address these efforts by engaging in open discussion and having a shared goal of centering the patient's actual lived experience. We believe that this resulted in a more holistic framework as well as a better understanding of each other's disciplines.
Our interprofessional approach allowed us to produce a framework that not only addressed the patient's immediate medical needs, but also proposed sustainable and justice-oriented interventions. This collaboration demonstrated how diverse disciplines, when united with a focus on social justice and patient-centered care, can transform isolated intervention into a comprehensive and equitable care plan. And this is our works cited.
Anyone have any questions for team? And if team one want to raise your hand. So your presentation was the framework, it showed up pretty quickly. I don't know if everybody catches, if you guys want to talk a little bit more about, elaborate on, what you guys thought about your patient needs.
Well, our patient did have many diverse needs. As mentioned in the title and on the presentation, she is a sickle cell anemia patient who's often hospitalized. She is currently living in a shelter, and she does not have a great proficiency in the English language, which makes all of her interactions extra difficult. So that's something that we try to be conscious of along all of our interventions and the framework that we designed for the patient.
Yeah, like you guys had, beyond the health, there's education, there's social justice and ethics and all those factors. And I guess I would use the same question that Chris asked the last team. What other professions you wish in your team?
I know from my perspective, I'm a DO student. I think it would have been really interesting to have a PA student on, just because I haven't had a ton of exposure to work with PA students, and just to see what they could bring to the table would have been really interesting.
I think I would have liked to have pharmacy. We didn't have pharmacy, and she was kind of medically complex and navigating her access to medication and what medications would be recommended and what other resources she may have for affording those medications would have been great. To be able to really consider that.
There's a question in the chat if you guys want to respond. Can you guys see it?
So in our original case, we didn't have her initially set up with a caseworker, but one of our resources that we were talking about was setting her and her family up with just a case management organization, so then they could work through that. And we also broke our interventions up in a couple different levels, so we could address individually, things that were impacting her, things that were impacting her family, her community, and then just globally or throughout the country at a public health scale.
All right, so this is the last talk in our session, interprofessional collaboration for quality patient care.
We have just a few seconds. I'm going to give a shout out to the Interprofessional Simulation and Innovation Center, Ashley Buckingham as the director, as they've worked together with faculty to develop these interprofessional cases, and there'll be more of them available in the spring. And so if you want to do an in-person interaction, that would be watch for that and sign up for that. You can learn about that in our weekly email.
That would be really great.
Hello, and welcome to an interprofessional collaboration for quality patient care. I'm CJ Greenway with an expected BSN in 2027 with several years of direct patient care experience.
And I'm Gina Kalari. I'm an expected DMD candidate in 2029 with a background in nonprofit social work.
Within this simulation, we had 3 students from different healthcare professions who collaborated together to deliver a quality care plan to our patient, Michael. It's worth noting that our third healthcare professional student is in pharmacy, but is not joining us for the showcase. Michael's a 74-year-old veteran who recently fell and cut his head. He lives alone in small rural Maine and has a very small support system. He gets his financial benefits from the VA and by doing odd jobs around his town.
We had 3 meetings with Michael, our patient, and in between each of those meetings, we met as an interprofessional team to debrief and create a treatment plan. So this is kind of an outline of our meetings. You can see we had 2 information gathering meetings with Michael with debrief sessions in between, and then the final treatment recommendation meeting.
In those meetings, all 3 of us went in with Michael, all 3 health professions. He was a little bit more reserved, arms back to the wall, hesitant to answer the questions. But we learned he had type 2 diabetes that was poorly managed and has a significant fear of falling again. We learned how he was getting to his medical appointments, getting his prescriptions, and discussed his goals moving forward.
During our debrief sessions, we really got to flex our interprofessional knowledge. Our 3rd team member, our pharmacy student, provided a lot of information around drug interactions and things that he had more expertise in, which was extremely helpful. CJ was able to provide expertise in diabetes management and home care with her nursing background. And I provided a lot of overall organization and other suggestions for home care management as well.
Our recommendations included providing him with a home health aide, purchasing Life Alert, and recommending different dietary recommendations.
We learned a lot from this simulation. When we gave our treatment plan to Michael and the simulation was finished, the actor who played Michael came in to meet with us and give us feedback. And he said that he felt that we had really clearly defined roles and excellent collaboration, which we really felt in the moment, I think. And he also gave us some really constructive feedback around overall exuberance and some medical jargon that we'll take with us in our future careers.
Thank you so much for watching, and we're looking forward to your questions.
Right, really lovely presentation. Anyone has questions? So can the team member raise your hand? All right. I have a really quick question. I think your program is really, really nice. You can have a direct feedback from your patient actor, and that's our virtual program cannot do. So how did you feel, when you have a conversation with the patient? Did he like the plan? And what did you learn additionally during that feedback time?
I'm happy to speak to some of the feedback. Sorry if there's a lot of background noise. So it was really interesting to receive feedback right after from the actor. It was at first a little alarming because when he started speaking to us as not Michael, we were like, wow, okay, you're not him actually. And he gave me some really good feedback that I'm going to take with me into my future career. I tend to be somebody that's a very exuberant person, and I'm like, oh, I'll lead with friendliness, and that wasn't necessarily well received initially by Michael. He was maybe tone down the exuberance a little bit if you see that this person is somebody that is kind of reserved, and he was sitting with his back against the wall, which I really appreciated that feedback because that was a definite growth area for me. And then he said in general that we did a really good job collaborating as a team, and he felt that it was clear in our roles and that we were very organized in what we were saying. So yeah, I don't know if CJ, if you want to add anything.
No, that about covered it. The only notable thing too is he also, like we said in the video, addressed that we used some medical jargon that he was not familiar with. And so again, using that moving forward when we're talking to patients, especially from rural areas that might not have the same access to healthcare or that health literacy too. So, but it was very interesting that we were able to get that feedback right away and just take that with us too moving forward.
Yeah, I was actually gonna I'm curious because you mentioned that Michael was a pretty reserved at the beginning. How did you guys open him up? What approach you used?
Honestly, I would say shout out to our pharmacy student who is not in the showcase. He is also from northern rural Maine, and so he was able to connect with him about that. And he was also very personable, but matched him on that level that Michael needed. and kind of open that gateway up to Michael opening up to us, which then kind of led the way for us. But I would say major shout out to Evan, our pharmacy student, who's not joining us for the showcase today.
That's really great because we always
Yeah,
tell
I
you
agree.
guys.
And
Oops.
oh, sorry. I
Go
think
ahead. Go
my
ahead.
internet's a little slow, but I agree. And I feel like the feedback that he gave about us coming off as a little exuberant in the beginning was good feedback. But then I also felt like that helped us. Like he warmed up to us and then ended up like really liking us. So it was kind of like this both and of like, yeah, maybe like we can be more conscientious of like how we start the conversation with somebody, but then like continuing to be yourself and being like friendly and listening and exuberant in that way, like does go a long way in building connection. So yeah, it was good.
Yeah, that's really great because we always are saying that a patient is on that we're on the team, right? So we want to include them. We don't want them be, close out and then not telling us what they're thinking. And it's actually your program to demonstrate that. And also they can be in your team for training as well. It was really great. Anyone else have questions? So I think this is the last talk in our session. And don't forget to log your attendance. The link is in the chat and it will be on the last slides in our presentation as well. But in the meantime, let's keep the conversation going. What did you guys all learn from your experience? We can talk about anything about interprofessional practice and education. It does not have to be related to this particular presentation.
I really like the Michael experience. I did it too. I think it's really, really helpful just to be in that lab at UNE. It's such a nice, lab in innovation. Just being there as much as possible just helps a lot.
Jennifer?
I have a question for you guys. So, with having, more limited people on your team, did you ever have any times that came up where you found that he was asking about questions or topics that you couldn't answer because it wasn't necessarily in your wheelhouse? And how did you manage to go through that?
That's a really great question. I felt like even though we were a small team, we were coming from such different specialties and we really relied heavily on our pharmacy students. And then CJ just has a wealth of experience in the nursing field as well that she brought to the table. And I have less experience in terms of being a first year dental student, but I had 4 years of prior work experience in like a social work field. So I really relied on that, which I feel like kind of helped add maybe an extra profession like in there. But yeah, CJ, if you want to add anything.
Yeah, that kind of is the gist of it too. And also in between each session, we had like 15, 20 minutes to talk about everything. And we had a big whiteboard and we identified any places that we were missing any knowledge. And really there wasn't a whole lot. The only thing we were truly missing was a physician. But like Gina was saying, with the pharmacy, nursing, and dental medicine and all of our backgrounds previously together, we really did make a good team and try to fill all those gaps in his social determinants of health.
Anyone else used the same case? If you want to chime in, how your team do?